So everything works?
Yes, we have started.
Okay, welcome. Welcome. I think if everyone can sit down, we can start the session. Everyone had their coffee break, so that is why. Okay, so let's start now.
Terrific. Thank you very much. Thank you again. Like I said, I'm very honored and humbled to be invited to speak today. And thank you to Bert and Pernilla for organizing this and for the work that they put in. And also thank you very much for accommodating my situation and allowing me to virtually present, as I was not able to be there in person. My name is Dr. Sasha Blaskovic, and patients generally refer to me as Dr. B because they can't pronounce my last name so easily. And so Dr. B is just perfect. I operate the Whiplash and Injury Clinic, and this Whiplash and Injury Clinic has two locations. One is in Langley, British Columbia, Canada, which is roughly 45 minutes east of Vancouver, Canada. The second location is in Lyndon, Washington in the United States, and that is roughly 1.5 hours north of Seattle. The two websites at the bottom of this initial screen, one is the clinical website, whiplashclinic.com, and the other one is my doctor website where international patients can reach me and share their imaging and clinical situations for potential advice and direction, and that is drblaskovic.com. The topic of today's lecture is a long, drawn-out topic, but hopefully it'll make sense by the time I'm finished today. But the title of the topic is The Involuntary Physiologic Neuromuscular Response to Atlantoaxial Instability and a Non-Invasive Method to Keep the Tone of this Involuntary Neuromuscular Response System Optimized. And again, thank you for letting me present virtually. You're all in Sweden enjoying Swedish coffee, and I'm in Canada having not as good a coffee as you are. I'd like to outline a few of the points I want to discuss today. There's 5 sections I'd like to discuss today. Pernilla had asked me to show some motion x-ray, which is what I specialize in, and I will show that at the end of the presentation, but I think initially an explanation of the pathophysiology of whiplash and how that relates to ligament injury, and then the neuromuscular response system for that will paint a strong picture to show why the indication of particular imaging modalities makes sense and what that can render as far as useful clinical and treatment information. So the first section will be an overview of a common rear end automobile collision and occupant vector biomechanics causing ligament injury. So the important notion here is that vector is a crucial component of trying to delineate what you predict may be wrong with somebody. And by vector, that indicates that there is a force and which direction the force is coming from. And then the biomechanics would relate to the anatomy and how the anatomy physiologically interacts with the anatomy around it and what kind of predictability you would have for different injuries to the ligamentous system, particularly for this presentation. Secondarily, an overview of atlantoaxial ligament injuries, and there are numerous atlantoaxial ligaments, and today particular attention will be paid to the alar ligaments, the spinal accessory ligaments, and the cruciate ligament or transverse ligament in the craniocervical junction. Overview, number 3 is an overview of the involuntary neuromuscular response and involuntary stability protection system of the deep atlantoaxial muscles. This is a crucial component to the body's attempts to combat permanent ligament damage resulting in ligament-induced spinal instability at the atlantoaxial junction and also the craniovertebral junction. And then fourthly, an overview of a common symptom list, which we're all presented with by patients who have had these types of injuries. And additionally, a call to clinicians to actively inquire of their patients for some more serious symptoms that patients generally are not trained to disclose themselves, but are more of a neurological nature that these patients often believe are related to something other than their injury, at least for the short period of time until they slowly start to figure out that it looks like it's related to their injuries. And then the last part, number 5, would be diagnostic imaging for atlantoaxial instability using motion X-ray, which is fluoroscopy in other words. And then I will also include some CT and MRI examples for these particular case studies that I will show you of the same patients that I do the motion X-ray for. So without further ado, let's get into the overview of the most common method by which the majority of our patients sustain their injuries and their problems, and that is a rear end automobile collision. So an overview of a common rear end automobile collision and the occupant vector biomechanics causing ligament injury. So I'm going to show you a model of a simple rear end automobile collision and what happens to an occupant when rear-ended. So at the initial onset of impact, and I'm going to take into account here that this patient is not guarding for the impact. So this is where the majority of the significant ligament injuries occur, when there's no guarding. Contrary to what often people believe in the public, is that guarding is a bad thing. Guarding is probably one of the best things you can do when you're exposed or predisposed to one of these collisions. But for this example, let's go on the notion that they're not expecting this to happen. So at the point of impact, the car seat starts to move forward. The occupant remains stationary due to the inertia, and there are no occupant forces. So as the collision progresses, at 100 milliseconds, the car seat gets pushed into the back of the occupant's torso, pushing their body forward, but their head remains stationary still. And so relative connection between their head and their body, or their head and their neck, you get shearing forces where the cranium is being forced posteriorly as the body's being pushed forward. So you have a shearing or a planar motion like this initially happening at that moment in time. And these shearing forces are focused and accentuated at the craniovertebral junction. The next component here is at 175 milliseconds, where the shearing turns into an extension or a backwards tilting with shearing and distractive or traction forces on the head as it relates to the neck, as the car seat and torso are being accelerated further forward. And then if we fast forward to the recoil moment of that, so when the body is shot forward as the car comes to a stop and the occupant potentially slams on the brake to slow this process down, they're shot forward as the car comes to a slowdown or a stop. And so then their head and torso are accelerated forward, resulting in a flexion of the spine, particularly the cervical spine, and then the head fulcruming into flexion and also being distracted. And the accentuation of this generally happens when the seatbelt tensioner goes off and the seatbelt stops this motion. And so you have the momentum pushing forward, and then the seatbelt stops that, which will put a distractive force on the craniovertebral junction, predisposing that area for ligamentous compromise. This is just a simple schematic showing the same thing. So initially, you can see on the left image that there's the cervical lordosis is maintained, and as soon as the acceleration of the vehicle and the seat and the torso starts to happen, there's a straightening of the cervical lordosis, which is, I would humbly suggest, is one of the most significant findings when we see normal röntgenograms or x-rays of these patients when they have a straightened lordosis or reverse lordosis. That is a red flag to look further. And then this is the moment where the shearing happens in a uniplanar motion like this. And then the next image shows the extension. So cervical lordosis is accentuated. The head rocks rearward or extends on top of the cervical spine with distractive forces on the head relative to the fixated body. And then upon the recoil, we have then a reversal of the lordosis with traction being put onto the skull axially upward and forward. So potential chance to injure the deep ligaments of the craniovertebral junction centrally anterior and centrally posterior of center in both of those scenarios. Now, an overview of the atlantoaxial ligaments and their injuries. And again, I'm going to focus mainly on 4 specific ligaments. And there are others, and I think they're relevant and important, but I think for the purpose of this lecture, I would like to focus on just a select few ligaments that I think are probably the most important from my personal experience and clinical experience. So some bony anatomy of the upper cervical spine. On the left-hand side of the image, we have the atlas at the top and the axis underneath that. Both of these bones are extremely unique as it relates to the remainder of the spine, and they have a unique function. And this region of the spine does not have any discs. And so the integrity and the functionality of this region is purely dictated by ligamentous integrity and neuromuscular control. The image on the right side is a depiction of the bony anatomy of the upper four segments of the cervical spine. And if you can see my mouse arrow here, if we remove the posterior elements of this region, and just a step back, my experience has been that lateral masses and the dens and the orientation of those structures is crucial at delineating subtle abnormalities in this region that would allow for further investigation. And so when we remove the posterior elements of this region, we can look inside, and then if we then superimpose the ligaments of the deep neck here, we see the following. On this image, the left picture is a delineation of what would be the posterior portion of the vertebral bodies of the upper cervical spine and the anterior portion of the foramen magnum, or the skull, with the green dot depicting the tectorial membrane. And as the tectorial membrane goes inferiorly, becomes the posterior longitudinal ligament that traverses the remainder of the spine along the posterior body margins. The image on the right is what we see when we remove the tectorial membrane at that junction point. Again, looking anteriorly from a posterior aspect, with the posterior elements being removed here. The red cross in the middle depicts the cruciate ligament. So this is the transverse ligament. We have the transverse bands and the superior and inferior cruciate. To the side of that, the horizontal portion of that red bar, we have the spinal accessory ligaments that traverse between C1 and C2 bilaterally. Superior to that, going at an angle from the dens up to the occiput, we have the alar ligaments, which I believe, again, in my personal humble opinion, are relatively important structures in pathophysiology of this region post whiplash or post injury. And then as we go forward, when we have damage to these ligaments, what is likely to happen is we'll have functional subluxations and functional stenosis occurring as a result of the suspension, the neutral suspension of these C1 and C2 orientations not being maintained at any given moment. And so back in 1977, we have, so some of this stuff dates quite a ways back. And in my experience clinically, I don't hear much, if at all, clinicians discussing these matters. It seems like these very smart individuals from the past, their work is slowly fading away. But we have the Fielding and Hawkins classification of Atlantoaxial subluxation, if you will, as a result of ligament compromise. And this causes then a functional stenosis. By functional stenosis, I mean that when the offset or the neutrality of the C1, C2 orientation is not maintained, we can have some level of stenotic forces being amplified at the atlantoaxial articulation as C1 offsets on top of C2, and the junction point between C1 and C2, so the neural canal, becomes narrowed at the junction point between C1 and C2, resulting in a functional stenosis. And this functional stenosis then leads to likely neurovascular compression. So we can have mild brainstem compression at any given moment. And as that is repeated continuously at a subtle rate or is held for a prolonged period in a mild fashion, it will result in cervicomedullary-like symptoms. Now, an overview of the involuntary neuromuscular response and involuntary stability protection system of the deep atlantoaxial muscles will explain this as follows. So it is involuntary, but it is critical in the neuromuscular mechanism that works during unstable atlantoaxial motion. And just a side note, my definition of atlantoaxial instability indicates that there's neurological compromise and the patient presents with neurological symptoms. Otherwise, my personal opinion, it would be to deem it hypermobility. And so because the majority of these patients present with neurological symptoms, and I will go over those symptom lists in a moment, I would render the diagnosis instability as opposed to hypermobility. Now, the three neuromuscular components that I want to discuss today, I think, are the most important, most relevant, and they relate to the following three scenarios: the muscle spindle activity, the Golgi tendon organ activity, and myodural bridge activity. So to start with the muscle spindle activity, I'm going to show you a diagram or a schematic of the muscle spindle. So skeletal muscle has within the extrafusal muscle fibers intrafusal sections that basically are referred to as muscle spindles. Now these muscle spindles basically provide input to the central nervous system by sensory neurons, and you can see the blow up or the zoom in portion on the right side here is the muscle spindle. So there is sensory input from the muscle spindle up to the central nervous system, and then the central nervous system responds by sending information back down through gamma motor neurons, and these control tone. So the resting tension of these muscles, as opposed to what the Golgi tendon organs do, which I will show you in a minute, which is reflex control. So the Golgi tendon organs are the immediate response to abnormal positioning or stretch or change in length of muscles at the atlantoaxial junction. And then the muscle spindles play a role in altering the long-term tone of muscle. So when patients present to us with repeatedly, chronically recurring tight and increased tone muscles in particular areas, that should be a strong tip-off that there's likely ligamentous damage deep to those structures, deep to those muscular structures. And so the muscle spindles are found nearly in all mammalian skeletal muscles. These muscle spindles sense muscle length and change in the muscle's length. So the velocity. And so it's not just the muscles change in length, but the direction of that change in length, which is crucial that these sensors send information to the central nervous system through. And the most densely spindled cervical muscles are the deep suboccipitals. This is a crucial point as it pertains to atlantoaxial instability and the governance of proper mechanics there. And most notably, the obliquus capitis inferior, which is a muscle that I've been fascinated with for 20 years because of my own atlantoaxial instability. I focused on it a lot. And this is our primary rotary stabilizer. Now, the obliquus capitis inferior has roughly 5 times as many muscle spindles as the splenius muscle, which would indicate that it is extremely important in relaying information to the central nervous system with respect to malpositions, subluxations, altered mechanics, so that the central nervous system can respond by elevating the tone of that region to protect primarily the brainstem and upper spinal cord. Now, this animation here depicts what the obliquus capitis inferior does in governance. So basically we have C1 and C2 here with a simple isolation of the obliquus capitis inferior bilaterally. And as this individual here undergoes right rotation of the atlas, if that right rotation is excessive, the left obliquus capitis inferior will stretch, the right one will shorten relatively. And at the Golgi tendon, which is where the muscle tapers into the tendon, we'll have a Golgi tendon response. So the Golgi tendon will send information into the spinal cord that the obliquus capitis inferior has excessively stretched. It will respond without going through the central nervous system, through the spinal cord, directly back through an alpha motor neuron to the obliquus capitis inferior, rendering it being forced to contract and neutralizing this position of the atlantoaxial articulation. And a patient can have this unilaterally or bilaterally. Generally, if they've been rear-ended, I find that they'll have this bilaterally because the compromise of the alar and accessory ligaments tends to be bilateral. If they've been impacted from the side in a side impact type collision, or as you'll see later, a side whiplash without contact of the head in a bicycle mishap, it'll have the same thing. So I'll run this through and let it finish. And then we'll go on to the next slide here. Yeah, so the Golgi tendon organ activity. So as I mentioned here, so this diagram shows a simplified version of the Golgi tendon mechanism. So the Golgi tendon is at the junction of the musculotendinous portion where the tendon will insert into the bone. This is prone to sensing stretch or change in stretch. It sends a sensory impulse into the spinal cord, which is relayed straight through the spinal cord back through an alpha motor neuron to the muscle itself, forcing a contraction. So simple example of this is a knee-jerk reflex. So we test the integrity of the neuromuscular system as it relates to the Golgi tendons on a daily basis when we check reflex activity. This then can become hyperexcited when we have the central nervous system being involved through the spindle problem, or even bulbar problems and upper motor neuron problems, like such as cervical medullary issues, where we would have hyperreflexia, as an example. Proprioception is the primary role of the inferior oblique muscle, as with the other suboccipital muscles, but again, the oblique inferior being by far the most important. It has roughly 240 some odd muscle spindles, if I go back to the muscle spindles, per volume of muscle tissue, and the other suboccipitals roughly in the neighborhood of 190. And then again, like I said, the splenius muscle, for example, and other cervical muscles have 1/5 of what the obliquus inferior has. Activation of this system utilizes simple monosynaptic or myotatic stretch reflex. This allows for accurate positioning of the head on the neck. Now, the myodural bridge activity. Myodural bridges were roughly discovered, I think, roughly in the mid-90s. And back then it was only thought that the rectus capitis posterior minor had myodural bridges, which would send information from the suboccipital to the spinal dura for proprioceptive and positioning and other mechanoreceptive properties. What we've discovered now, or what they've discovered now, is that every single suboccipital muscle that would be pertaining to, in this case, the atlantoaxial and craniocervical issues, has a myodural bridge. And this is one of my favorite diagrams here. This is an axial section of, again, I said the lateral masses are important to me. The position of the dens is important to me. Within there, we have the cervical medullary, or the upper cervical spinal cord, and the lower part of the medulla of the brainstem, and we have the right obliquus capitis inferior, the left obliquus capitis inferior. They've torn away the rectus capitis posterior minor and major, and so this star or asterisk here shows a myodural bridge going between the obliquus capitis inferior and the spinal dura. This is a very important structure as it pertains to several physiologies or pathologies, such as tension headaches, balance and coordination. And what is interesting is that the myodural bridge in cervical extension, its intent through coordination by the suboccipital musculature is to actually keep tension or maintain tension on the spinal dura to prevent or avoid infolding of the spinal dura to protect the spinal cord and brainstem from impingement upon itself. So regulation of tension across the myodural bridge as a spinal cord stabilizer may prevent dural infolding, reducing stimulation of nociceptive pain mechanisms. And when we have hypertrophy or hypertonicity, in the sense of in the case of clinical instability of the suboccipital muscles, or a failure of the system to maintain constant tension, it may result in clinical manifestations arising from increased dural tension. Now, the overview of the common symptoms that patients present with, and then I have a call out to clinicians to actively try to engage patients in asking some more serious symptom questions, and I'll include that symptom list here as well. And it is quite an extensive list, and this is not all inclusive, but some of the main ones that I encounter and I find relevant to ask patients about, in addition to just the pain ones that are the common ones here. So the common symptoms related to atlantoaxial instability that we'll encounter would include neck pain, shoulder pain, jaw pain, occipital headaches, migraine headaches, tinnitus, either on one or both sides, tenderness at the base of the skull, dizziness, vertigo, nausea, difficulty with concentration, photophobia, phonophobia, blurred or double vision, and fatigue. So some of the more vague symptoms that patients generally will not relay themselves and should probably be inquired about by the clinician relate to more of the neurological manifestations of atlantoaxial instability. And these include, again, this is a limited list. There are more, and the list is constantly growing, but the following include the difficulty swallowing or sensation of being choked, a hoarse voice, and or having to frequently clear your throat, runny nose or runny sinus and or persistent post-nasal drip, feeling like a bobblehead, like the skull may fall off the spine, feeling of plugged ears, like you're going up in an airplane and they pressurize constantly or regularly, a whooshing sound in the ears, sometimes referred to as pulsatile tinnitus, tremors, and these can be gross tremors that are very visible, or just a minor subtle tremor that the patient feels where they feel like they're on edge and electrified, hot flashes or cold shivers, so temperature control regulation issues, heartburn or acid reflux, diarrhea or constipation, an increased urgency to urinate, even when not hydrated, orthostatic intolerance, fainting, weakness of the limbs, heart palpitations, shortness of breath, excessive sweating, irritability or being quickly angered, Lhermitte signs, so electric shocks, and these could be in the extremities, in the torso, or even in the head. Cognitive and memory decline. So memory is generally short term. So for example, going from one room to another room in your house, going to get an object, and by the time you reach the second room, you've forgotten why you left the first room in the first place. Generally long term is not affected. Clumsiness and or fine motor control difficulties. So doing up buttons on a shirt, tying up shoelaces, penmanship, so how you write, becoming more messy, and feeling of coming down with a severe flu, but yet feeling better in 1 or 2 days, as opposed to it progressing into a flu. And lastly, diagnostic imaging for the atlantoaxial instability using motion X-ray, again, fluoroscopy, with some computed tomography and MR atlantoaxial injury or instability examples. And these are, they're going to be 3 case studies that I'm going to show of my patients. And the first 2 I will show conventional imaging and additionally motion X-ray imaging. And with both the conventional and the motion X-ray imaging, this is how I proceed to evaluate imaging studies that patients internationally or locally submit to me for evaluation or a second read. I don't claim to be an expert in this. I have a passion for it, and I feel that specifics are crucial, and relaying again the clinical presentation to the patient's imaging is essential, and not keeping those things separate. And so the way I would annotate this and then either explain this via Zoom call to a patient, or if they require it in a written report, I can accommodate that as well. And the motion X-ray reports, I always do written format, where I will take out still images, as I will show you in a moment, and I will embed those still images in the written report so that the text or the explanation is referred to by way of images, so that anybody reading the report can have a comprehension, or a better chance at a comprehension, of the pathophysiology that is occurring. So we'll go into this. The motion X-ray, oddly enough, is neither a new technology, nor is it a new utility for assessing aberrant spinal motion. So dating back to 1966, Buonocore et al. In the Journal of the American Medical Association quoted the following: the ability of motion X-ray to demonstrate localized abnormal motion in the cervical spine allows one to predict soft tissue injuries and the quality of spinal fusions, spinal stability, and early subluxation of the cervical spine in conditions that may not be identified on static X-rays or other imaging, nor at physical examination. So what's interesting to see here, or what's interesting to note here, is the prediction of soft tissue injuries. And that is a very, very eloquent way to put it, because we do not see the actual damaged ligaments on motion X-ray. We have to deductively reason through known anatomy, known physiology, to be able to delineate where we see aberrant or abnormal excessive motion, and knowing the anatomy that is there and having an understanding of how that anatomy is supposed to function physiologically, to be able to say this is excess, this is the tissue that should be preventing that excess motion, and thereby it, through deductive reasoning, is the tissue that has been compromised, resulting in the aberrant motion. And what's interesting as well is also assessing the quality of spinal fusions, and also potentially the integrity of the hardware, where there's suspicion of potentially loosening of hardware. This type of modality becomes essential, because you can functionally assess motion to determine whether or not the integrity has been maintained and something else is causing a potential flare-up, or whether it is actually the hardware integrity that has been compromised. Okay, so case example number 1. This patient, I will show conventional imaging, and I will also show motion X-ray on this patient, confirmatory to the conventional imaging. So we have a 35-year-old female. She lost control of her mountain bike, and her head was whipped to the left forcefully. So no head contact was made, just a forceful whipping motion. Her symptoms included right upper neck pain, right face pain, right eye pain, with electric shocks going across her eyes, sometimes left to right, sometimes right to left, headaches, fatigue, dizziness, right side tinnitus, anger, heart rate, and blood pressure fluctuations and temperature control issues. The imaging that was conducted conventionally included a head and brain CT, head and brain MRI, neck CT with the craniocervical junction included, and a neck MRI with the craniocervical junction included. All studies conducted were done in neutral and in the recumbent position. And then, interestingly, all studies were reported as unremarkable and specifically stated atlantoaxial level being normal. Now, the CT and MRI of her head and brain did not pan below the occiput. And here I would like to add a sidebar to all clinicians listening to this. Upon ordering a CT or MRI of the head and brain, I would plead that you request that imaging in all three planes include down to the level of C2 so that the craniocervical junction and atlantoaxial junctions can be assessed with this, because I find that this is an area where the missing link happens to be in a lot of these cases. Thankfully, this patient did some research on her own, and she demanded that her neck CT include the craniocervical junction, and that's why it was included. So I'm going to show you some samples from her cervical spine CT scan, and you can tell me if you see the abnormalities, and obviously I will annotate the anomalies or the abnormalities for you, but I think it's good to just try looking at this for a second yourself to see if you see anything, and hopefully you do. So this is an axial image of the atlantoaxial level, and so with CT scans, conventional imaging, the right side of the picture is the left side of the patient's body, the left side of the picture is the right side of the patient's body, the bottom of the picture is posterior, the top of the picture is anterior. And so I'm going to zoom in on this, and if you haven't seen it already, I'll zoom in on it a little bit more here so you can see. I'll give you a second to take that in, and you can think for yourself if you, I would be testing you right now if I was there for hands up. And so this one here, and I'm going to show you with annotations what I see. So what I see here is that the periodontoid spaces on the right side, which is the left side of the screen for us, it measures at 4.6 millimeters. And the periodontoid space on the patient's left, which is the screen's right, is 1.25 millimeters. Those are not congruent. And that is a very strong tip-off that there is ligament compromise in this patient at the atlantoaxial junction. On the next image here, it's the same thing blown up. And so what I've done is drawn lines here at the notches of the dental facet at the posterior aspect of the anterior arch, where the dens is supposed to roll around in. And so you can see the green line is the patient's right, screen's left notch, and on the red line is the patient's left, screen's right notch. And you can see how the odontoid does not fit into the center of those. So this is an additional annotation showing the same thing. And this next image here shows on the left side the level of C1, and you can see that C1 is horizontally oriented. It is not rotated in any way. And the picture on the right is the exact same scan, so the patient was not moved, and you can see that at the level of C2, the patient has left rotation of C2 of 8.2 degrees. This is very significant. And going further into that, so the sagittal views of this exact same CT scan, the image on the left is the patient's left C1, C2 articulation orientation. You can see vertical alignment of C1 and C2. The image on the right shows the patient's right C1, C2 articulation and the orientation, and then you can see anteriority of the C2 superior articular facet. So the coronal view of this as well shows incongruency in the periodontoid spaces, which again, to me, is a strong tip-off for atlantoaxial ligament compromise. So with this patient, after multiple failed courses of conservative therapeutic treatment modalities such as physical therapy, massage, chiropractic, trigger point injections, nerve block injections, medications, vestibular therapy, acupuncture, elimination diet, psychology, exercise therapy, and ears, nose, throat triage, she discovered the existence of motion X-ray for the cervical spine. She sensed that her neck did not feel stable, and she wanted it investigated. So she referred herself. So I'll show you some still images from her motion x-ray. And you will see, so the fluoroscopy is not reversed like conventional imaging. So what's on the right side of the picture is the right side of the patient's body. What's on the left side of the picture is the left side of the patient's body. And here we can also see the periodontoid spaces with the arrows not being congruent. So the right side being more than the left side. And on the bottom of the screen, this is what I do with each of the motion x-rays that I conduct on the cervical spine is I will attach a radiopaque certified ruler to the patient's neck so that I can use that to calibrate my measurement software so that I can minimize the margin of magnification error to the lowest factor possible. And so for each patient, I will manually do that and manually calibrate my software so that I believe that I have the most accurate rendition of the quantity or quantification of their abnormality when I make measurements. Now, this is the same patient when they go into left tilting or left lateral flexion of the head on the neck. And the measurement that is taken from this is 5.4 millimeters. So her lateral mass on the left overhangs the superior articular facet of C2 by 5.4 millimeters. What's also of note and of interest here is that her periodontoid spaces become conform. So they're equal bilaterally in this position. So when I blow that area up, it's a little bit blurry, but it's the best that I could do in getting this thing blown up, is that you can see the vertical alignment of the lateral margin of the lateral mass of C1 ends right about here. Hopefully you can see my mouse arrow. And the vertical alignment of the superior articular facet of C2 is here. So this distance right here is the level of overhang of C1 on C2. And now this is an alar and accessory pathology on the opposite side. Conversely, on the patient's right, when she bends her head to the right, there is a minimal, if at all, overhang of the lateral mass of C1 on C2. And this is an interesting point because when there's a bilateral overhang, and rightfully so, I get a lot of clinicians asking me, well, isn't that normal? Should that not be what we see? Isn't there supposed to be motion there? And my answer to that is yes, there's supposed to be motion there, but not overhang. And so one of the two is true. Either the overhang that we just saw on the left is correct or expected or proper or normal, or what we're seeing on the right-hand side here is correct, proper, or normal. They can't both be correct, proper, or normal. This is a wonderful example of being able to explain that by conducting motion x-ray and seeing a difference, and thankfully in this case, this was a side impact, or not a side impact, a side whiplash type scenario where we wouldn't expect bilaterality of the pathology. And that's exactly what we're seeing in a rear end collision where it's uniform bilaterally. We would generally see bilateral overhang that's close to the same on both sides. There may be some variation, but that would then pose the question, well, isn't that normal or isn't that expected? And my answer to that would be no, after seeing thousands of these on thousands of patients. And so what we're seeing here as she bends to the right is subtly abnormal, but I would consider it definitely normal compared to her left side. And so when I expand or blow this up, you can see vertical alignment or continuity between the C1 and C2, indicating that it's different than what we saw on the left side. Now, this is a portion of her motion x-ray with the lateral tilts. And then you can see this event happening in real time. And so from this real time is where I would freeze frame the most incriminating moment visible, and then I would measure it, annotate it, and that's what makes its way then into the motion x-ray reports as evidence of ligament injury. So I'll run the video here. So she bends to the left. You can see on her left side here, the C1, C2 overhang of the lateral mass. The congruity of her periodontoid spaces has taken place. And then as she goes back to the right side, and if I freeze it there, you can see that there is no overhang, and if there is, it's extremely minimal compared to the left. So this is what I would expect. Now the periodontoid spaces have become incongruent. So these are all signs of instability. Oops, sorry, I apologize. I got overly excited and went to the next slide. So I'm just going to run the video for you again. You can watch it in real time. So repeatedly as she goes to the left, there's overhang, and repeatedly as she goes to the right, there's very little, if any, overhang. Now, the conclusion for this young lady would be that she will likely receive great benefit from atlantoaxial fixation surgery, and this fixation will likely provide her with the best chance of return to the most functional version of herself possible. And the main goal here is that I believe that her neurological manifestations will be mitigated by atlantoaxial fixation, and thereby likely the pain and headaches as well. And this has been proven time and time again by the wonderful work that the other distinguished presenters, Dr. Goel, Dr. Lafuente, and Dr. Visochi have, I'm sure, experienced many times. Now, the second example here of this case study is a 49-year-old male who struck a deer with his motorcycle and was thrown off, and he flipped 3 times. Each time he flipped, he hit the back of his head with his helmet on, and therefore 3 times had a blow to the back of the head. At the scene, he had a mild loss of consciousness. Obviously, he can't remember for how long, and he had elbow, shoulder, and chest pain. He was taken to the hospital, and x-rays were taken of the elbow, shoulder, clavicle, and chest. All reports and results were unremarkable. Symptoms began a few weeks later and included neck pain, headaches, pain at the back of the throat when swallowing, progressive weakness, first in the left leg, followed by the right leg, and then bilateral arms and hands. Fine motor control and speech began to deteriorate, and then facial pain, tinnitus, dizziness, diarrhea and constipation, breathing difficulties, anger, heart rate and blood pressure fluctuations, and temperature control issues. Now, interestingly of note here is that the first cervical spine and/or head brain imaging was made 7 months after the trauma. And the reporting found only degenerative changes in the mid to lower cervical spine, and comment was specifically made that the atlantoaxial joints were normal. So I'm going to show you some of the still frames or some of the images from the conventional imaging conducted on this patient. So this was the conventional x-ray that was conducted 7 months post trauma. And what I would note here, and then you can see tying back to case 1, is that we're seeing the same thing here. So the periodontoid spaces are not congruent. One might be able to argue that this is a positioning problem, etc., but I would suggest that based on the trauma, based on the clinical presentation, there should be a suspicion of atlantoaxial craniocervical ligament compromise. Secondarily, and also not noted in the report, the blue arrows delineate rounded bulbous structures that are the posterior arch of C1, and the big yellow arrow shows that this gentleman has a spina bifida occulta, which may or may not have contributed to the severity of his injury. Now, from his MR, the next screenshot that I took from his MR shows a clivo-axial angle of 130.8 degrees. And this is in neutral, recumbent. An angle below 135 degrees is considered pathological, especially when bulbar symptoms are present, as per Henderson et al. And this gentleman definitely had a diagnosis of bulbar symptoms. Cerebellar tonsillar ectopia. His cerebellar tonsil, at my measurement there, this is almost mid-sagittal, but is probably a hair para-mid-sagittal. I measure at 5.65 millimeters. Now, whatever the measure is, whether it's 3 millimeters, whether it's 2 millimeters, or whether it's 5.65 millimeters, the point of the matter is that the cerebellar tonsils should not protrude caudally through the foramen magnum. This finding is very significant, especially when paired with the clinical presentation of this patient. And then lastly, the last finding from his conventional MRI that I found is a left medullary dolichoectasia. So dolichoectasia is basically considered a tortuous artery that, in this case, is his left vertebral artery, is indenting the left part of left ventral part of his medulla oblongata. And you can see the red arrow showing that and showing the indent of his medulla. And then on his right side, we can see the vertebral artery very well distanced from the medulla. Now, this is, again, a significant finding, specifically when paired with his clinical presentation, okay? Now, I'm going to take a still frame from his motion x-ray, again, unique. So this is a moment in time from his lateral projection where he's proceeding towards cervical extension. And what we see here are the 2 arrows delineating the ramus on the left and the ramus on the right of the posterior arch. We should not be able to see that light oval space between these 2 arrows, which is basically the posterior arch, inside the posterior arch. So this indicates that his atlas is tilting to the side when he goes into extension, which is a further indicator of atlantoaxial ligament compromise. A further note here is that we can see, now that we know that he's got spina bifida occulta, is that there are two distinct bulbous structures back here, which are the two components of his posterior arch that were not fused and are have remained patent as spina bifida occulta. Lived his whole life without knowing it. Now, this is the video of his lateral projection, and this is considered what we call a nodding video. So what he's going to basically do is he's going to project his head forward or protrude his head, and then he's going to pull his head back or retract his head. The main goal of this is to basically assess the occipital-atlantal articulation, or how the occipital condyles rock back and forth in the superior articular facets of C1 of the lateral masses. Now, of note in this gentleman is that there is no motion in that articulation, which is because I believe that the trauma that he endured possibly caused either a partial dislocation there and mild fracture, and what has resulted in an autofusion over time in that position. But you will note here that he has a lot of difficulty in jutting his head forward and coming back, that he's shaking a lot. And the gap between the occiput and C1 does not change. The gap between C1 and C2 does change. Plus, the side tilting of the atlas is visible to some extent on this video as well. So I'll play the video and you can observe for yourself. So you can see how he's shaking a lot, and he goes forward and there's no change whatsoever in that orientation. And there is change between the C1 and C2. I'll play it one more time. So you can see he has a lot of difficulty with that. Now, the conclusion in this patient's case is that the rapid deterioration absolutely requires urgent occipito-atlantal and atlantoaxial fixation surgery. I think that's going to be life-saving if this happens for this patient. Now, the final case I'd like to go over here, and I'm not going to include any conventional imaging on this one, just the motion X-ray. And the reason I want to show this one is this is the typical patient that presents on a regular basis for motion X-ray analysis. She has a bilateral overhang of C1 and C2. And in her case, she's a 44-year-old female with history of multiple concussion and whiplash injuries that didn't seem to cause much discomfort at the time. And this happened over the course of her life. And she, as of late, has shown a slow and progressive worsening of her symptoms with no obvious temporal link to recent trauma. So there's no recent trauma that she can link her current progressive worsening of symptoms to. Cervical X-rays, head and neck CT scans, and head and neck MRI scans conducted relatively over the past decade, the reports were always unremarkable. The only significant finding that I found on her MRI was that she did have cerebellar tonsillar ectopia, roughly 3.5 millimeters. Again, not fitting the criteria for Chiari 1, but I think significant in her case based on the clinical presentation. And again, reiterating the fact that clinical presentation combined with imaging is crucial. Now, her symptoms include upper neck pain, bilateral face pain, bilateral eye pain with electric shocks through the center of her head, headaches, fatigue, dizziness, tinnitus, anger, heart rate and blood pressure fluctuations, temperature control issues, regular bowel and bladder difficulties, brain fog, blurry vision, hoarseness of her voice with constant phlegm buildup in her throat. You can see that there's a strong overlap with a lot of these patients as to some of the neurological manifestations alongside the pain that they have. Again, multiple failed courses of conservative therapeutic treatment modalities. She also had physical therapy, massage, chiropractic, trigger point injections, nerve block injections, medications, vestibular therapy, Botox, acupuncture, elimination diet, psychology, exercise therapy, and ears, nose, and throat triage. Ears, nose, and throat is one of the most common things that atlantoaxial instability patients get referred to at some point in time. Now, she also discovered the existence of motion X-ray for the cervical spine, and also self-referred herself. I'll play her video, and you can see bilateral overhang of C1 on C2. Again, the most common presentation. And again, most common question I get from physicians is, isn't that normal? Isn't that expected? And as you saw in example 1, it shows I believe, strong evidence that overhang is not normal, and having it bilateral is also considered abnormal, especially again when paired with clinical presentation. So play the video. And you'll note in her case that the periodontoid spaces remain relatively congruent. And she's been pretty good at positioning herself. So we can see an overhang on the right. Periodontoid spaces, maybe a slight variation, but relatively conform. She goes to the left. Again, we have an overhang, relatively conform in the periodontoid spaces. And I'll run it through. Now, in her case, she has responded extremely well to a technique that I utilize on myself and also on patients, and it is referred to as NIMO, receptor tonus technique, with tonus being the important key word there. Now, it aims to reset the functionality of the muscle spindles, the Golgi tendon organs, and the myodural bridges, restoring a healthy neuromuscular tone, again, tone being the key, and responsiveness of the involuntary action of the suboccipital muscle group when the atlantoaxial instability is present. NIMO is a manual treatment technique which utilizes specifically directed acupressure to muscles for extended periods. Now, my personal clinical experience is that a minimum of 20 seconds acupressure to the patient's maximal tolerance with a maximal recreation of referral patterns of headache and pressure into the head has shown to be most effective. Now, this technique has been shown to be very effective for non-surgical cases of atlantoaxial instability. Now, I've been living with what I would consider non-surgical atlantoaxial instability for 26 years, and I've been able to mitigate. And unfortunately, but yet fortunately, I've discovered it. But unfortunately, this is a daily regimen that needs to be repeated multiple times a day to hit that reset of responsiveness and to reset the tone of those suboccipital muscles. And they do coordinate the atlantoaxial junction relatively well for the most part, most days. And so the benefit of this technique, what I think is wonderful, is the empowerment and the ability that the patient can be taught how to self-administer this technique. So initially they would require a clinician to perform this on them, and hopefully they can tolerate the pain inflicted with the treatment technique and are willing to implement it on themselves for the desired results. And again, this becomes a daily regimen required to repeatedly reset the tone and the responsiveness of that involuntary system, because the underlying problem is permanent ligament damage to the atlantoaxial and craniocervical ligaments, resulting in recurrent Fielding-Hawkins type classification of subluxations and functional stenosis that will then cause either long-term low-grade compression of the cervicomedullary junction, or will repeatedly bump up against the cervicomedullary region, and in both cases resulting in neurological manifestations that could likely become progressive if not dealt with either by this non-invasive method or by potentially invasive methods surgically. Now, thank you very much for listening to me. Hopefully that all made sense, and hopefully I did not go too fast. And that is not me on the x-ray, but it is a funny x-ray that I found, and I love it. And so that brings me to the conclusion of my presentation. And if there's time, I'm happy to take questions. I'm not sure how we do this, if they're posted on the screen or if people will just ask them, but I'll leave that with the moderator to address that. Thank you. And I'll leave my contact information on the screen here for reference purposes, and the email address. Thank you very much. And again, it was an honor to present, and sorry that I couldn't be there, and thank you again for accommodating a virtual presentation. Thank you.
Thank you. Thank you, Dr. Blaskovic. Do the audience hear me okay? Mm? And Dr. Blaskovic, are you hearing me okay?
Hearing you perfectly, yes.
You are?
Yes.
I can't hear you now.
Oh, did I mute myself? Yes, I can hear you perfectly.
Okay. I have a problem hearing you. Please help. I cannot hear Dr. Blaskovic anymore.
Can you hear me now? Test one,
Yes,
test.
yes, now I can hear you. We can hear you all.
Perfect.
Thank you so much for your interesting presentation. I will start with a few questions and then we will turn to the audience here. I wonder if patient number one, was the incongruence of the joints not visible on a CT scan of the cervical craniovertebral junction?
Sorry, can you repeat that again? I'm hearing an echo.
Okay. Was the incongruence of the joints not visible on the CT scan over the craniovertebral junction?
I understand pretty much all of your question except for the first part because I hear you twice. I'm sorry about that.
Okay. Was the incongruence of the joints not visible on a CT scan?
Incongruence?
Yes.
Yes, go ahead.
Was it not visible on the CT scan?
It was, yes, and I showed that.
So
Yes.
could you be able to set that diagnosis on the CT scan without the motion radiographs?
Yes and no. You can see, as you saw in the neutral of her CT scan, that the only thing that was visible was a subluxation. So in the motion component, you actually saw that she had an overhang. So for example, in her neutral open mouth X-ray, she had incongruent periodontoid spaces, but her lateral mass and the superior articular facets of C2 are aligned. And so this is why oftentimes this becomes missed as far as being reported on by radiologists, because they either don't look for that, or if they see it, they presume it's a normal variant. And once you do the motion, you can actually see aberrant motion, which will delineate the integrity of the ligament structures that should be coordinating functionally the proper positioning of the atlantoaxial articulations. So for me personally, as a clinician, it tells me a lot of information to see that incongruency, but when you do the motion X-ray, you can actually see abnormal slippage, which you cannot see on a static neutral positioned, whether it's an X-ray, CT scan, or MRI.
And was the ligament injury, was it done MRI over the craniocervical ligaments?
Yes, but there was never a specific study done for those ligaments. It was just a generic cervical MRI or cervical CT study, and so there was no special attention to the craniocervical ligaments as far as a specific study done. And even when those are done, oftentimes because the ligaments don't follow any single orientation anatomically, like the coronal orientation or the axial orientation or the sagittal orientation, and depending on the slice thickness of the MRI, it's a strong possibility, and I've seen this very often, that any possibility of that showing up is rendered not useful because of slice thickness and or the orientation.
What are your cut-off values on your measurements on these motion radiographs to decide if a patient should be treated with fusion or not?
There is no, this is a great question, and I've spoken with multiple neurosurgeons globally about this, that there is no direct correlation between the amount of quantification or amount of measurement and the clinical presentation of the patient. So there are anatomic variants of the spinal canal diameter, the anatomical variants in the thickness of the spinal cord and brainstem as it pertains to that canal diameter. So some people will have less of a measurement, but more neurological manifestations and symptoms because of the other factors involved, and other people, and for example, like myself as well, my total, so this lady that I showed you, her total, and you have to include the bilateral measurements. So if hers was 5.4 millimeters to the left, and let's say it was 1 millimeter to the right, or maybe 0, so she would have a total of 5.4 or 6.4 millimeters at C1, C2, and her clinical manifestations are extreme. Someone like myself, I have roughly 14.5 millimeters combined, and I can function, let's call it normally for the most part, most days, and I do have flare-ups and I do have, daily issues, but compared to the manifestations that she presents with, there isn't a direct proportionality or a cutoff where I would say, above this measurement, that indicates a serious pathology, and below this one, it's not. There are cutoffs for determining whether something is a permanent and ratable impairment, according to the American Medical Association. But my argument would be that the clinical presentation and the magnitude of symptoms and dysfunction that the patient is having, correlated with the measurements being abnormal, is the better rule of thumb to use to determine treatment, whether it be invasive or non-invasive.
Thank you so much. Now I will turn to the audience. Can you help with
Hello, Sasha. Can you hear me?
Thank you. I can hear you. Okay, maybe speak up a little bit.
Yes. Better now?
Yes.
Yes. Well, thank you for a fantastic talk. Very illuminating, particularly on the physiopathology side of things with the muscles, all these things that really clarify a lot of stuff. Unfortunately, we cannot see those findings on routine MRI or any other investigation. And you are trying to identify that directly through the motion X-rays, which actually give you sign of some real information. Do you think there's a imaging that could be potentially reassured at present that can help you to identify damage, muscular damage, maybe some blood tests, I don't know, any specific tests that have to do with radiology, maybe biopsy or something, just thinking out loud, because that will give us a lot of information, and that will take us all the concerns that we have. But some of these cases, we are not entirely sure that this instability, although typically doesn't show radiologically with that great evidence, that we can do an operation and fix them and get it better. Thank you.
Thank you. Yeah, thank you very much. That's a great question. I think where a partial issue arises is the time frame that it takes for MRI imaging to occur in these cases. It would be wonderful and ideal if a person had an acute injury resulting in these symptoms, if we were able to MR image them within the first 4 to 8 weeks after the injury. I think there would be findings that are relevant to inflammatory findings, such as high intensity zones or acute inflammatory markers on the MRI in these muscles that we could then propose and confirmatory to muscular injury as well, or muscular hyperactivity. I think once the problem becomes more long-standing, the chronicity of the appearance on imaging makes it really difficult clinically to determine which structure is doing what and which structure is overly responding. And it becomes, again, I think, then a clinical manifestation where the clinical presentation of the patient and a thorough correlation of subtle imaging findings relating to the clinical presentation need to be assessed and triaged that way. As far as an optimal imaging modality, I would love to see somebody one day invent CT fluoroscopy or MR fluoroscopy, where you can actually delineate these structures 3D in motion. That would be, I think, the most ultimate imaging invention in history. And I think Dr. Damadian would probably jump with joy to see something like that happen. He's the inventor of the MRI. Wonderful man.
Yes.
Okay, we have one more question.
Thank you so much for your wonderful presentation. I'm Simon Shocking from Gallery of University of Rome. And you showed us a great horizon of neurological options and clinical options to identify and focus surgical and non-surgical issues. When you showed us your summary clinical presentation of patient in the heart rate is C1C2 stability depletion, you underline all those symptoms as depending from C1C2 instability. This is really interesting subject to discuss. But in a couple of patients, you reported hearing loss and facial dysfunction as possible clinical related symptoms to C1C2 instability. Can you explain how pathophysiologically you can link these apparently far from C1C2 district to the district you treat surgically or in a conservative way?
Yes, thank you very much. That is a great question. I would answer that by stating the following. I tried to focus the presentation on the atlantoaxial articulation, and so I didn't get too much into the occipital-atlantal or other things that are related to this. But in response to the question, the pathophysiology of the particulars that you're asking, if I can explain it as following: when we have atlantoaxial instability, the Fielding-Hawkins phenomenon takes place. And so what ends up happening is the drainage channels for cerebrospinal fluid coming through the foramen magnum region at the level of the atlantoaxial articulation become compromised. Because of that functional stenosis, we have a back pressure or a backup of CSF. So the CSF continues to be made. So we have the blood-brain barrier. We have the person's blood pressure and heart rate pushing blood up against the blood-brain barrier. The plasma goes across the blood-brain barrier. The cells stay in the blood and continue to circulate. The rate at which the plasma goes into the blood-brain, across the blood-brain barrier into the ventricles, and then the cerebrospinal fluid is manufactured at the rate of the plasma shunting across, and thereby the same amount of drainage should happen through the foramen magnum and the atlantoaxial region to maintain an equal amount of pressure calibration. When we have a functional stenosis at the atlantoaxial articulation, in particular for this example, we have a mild stenosis to a more than mild stenosis of the drainage channels of the CSF, rendering back pressure. And so the back pressure can cause mechanical compression either from within or as it pressurizes back inward of the pons, the midbrain, and the medulla, and even up in the cerebral hemispheres as CSF starts to seep out of the ventricles and into the parenchyma of the brain. And so I'll go back to Dr. Demadian. He's done a great amount of research and study on this with the upright phonar MRI in New York, where he's actually delineated both these functional stenotic spots by upright MRI in different positions, and he utilizes mainly flexion and extension. But he's also devised a hardware that is able to be connected to the MR, and there's a pulse meter that attaches to the patient's finger, which then senses their heart rate. And because the heart rate is continually fluctuating, and the link between the heart rate and the plasma shunting across the blood-brain barrier is synced, that this pulse meter can actually coordinate an impulse to the MR scanner so that every time there's a pulse, that the MR actually takes an image. And so he's able to make a cineradiographic loop of the CSF circulating to be able to show that there are restrictions in flow void of the CSF through the upstream and downstream portions, rendering CSF pooling in the brain to some level, resulting in these, what he calls the craniocervical syndrome, which are basically nothing other than what we've been talking about this entire day here. Does that answer the question?
Yeah, thank you, Dr. Blaskowitz. Soon this session will end. I think it's going to end in just 3 or 4 minutes. Can we take one last quick question?
Thank you. Thank you for really interesting cases. I just want to clarify one detail in the case number 2. You showed the indentation of the abdomen by vertebral artery as a significant finding. And as we know, it's not common to see this. And so it's most non-variation. It's your interpretation that it how systematic was this experiment because of this?
Brilliant question, and I can't answer that with any certainty because there is no pre-trauma MR of the same region, so it's really hard to say. And the article
that would not be altered by surgery anyway. So I was just wondering whether it's indirect.
Yes, I think it is. And if you I'll go back to the citation article, and if you want to contact me, I can send you the article. I've got the full copy of it. But if you go to PubMed or somewhere, it's right there. It's so Savitz et al. 2006, and this is specifically an article that I think tracked either 6 or 9 patients. Don't quote me on that. That had medullary dolichoectasia and cervical medullary symptom patterns that, when operated upon, were completely resolved. So I can't definitively say in this patient, but it is definitely a finding that is not commonly seen. And I do commonly see it when I ask the question of neuroradiologists. Their comments are that it's a normal variant, and it's possible that it is a normal variant, but I think sometimes their lack of clinical information that they get with the referral maybe has them predict things that may or may not be the case.
Sasha, maybe you will coincide with me. This may be like happens when you do micromuscular depression on a content. You know that the investigations on how to do blood pressure by compressing actually on the brain stem. So this is really unrelated to Atlantoaxial instability, although it could be unusual for the course. Thank you very much. Can I ask you a very quick question? Unrelated to this. Are you close to Friday or by home?
I'm sorry, I didn't catch the last part.
Are you close to Friday or to Mount Baker?
I'm sorry, Mr. Lafrente. The Zoom session will end now in, I think, a few seconds. So
I'm right in between the two. I'm right in between the two.
Dr. Blaskovic, thank you for participating.
My pleasure. Thank you very much for having me. And enjoy the rest of your day. I wish I was there.
Me too. Okay. I think it's just a matter of seconds now that we will lose Dr. Blaskovic, and this session will end, if I'm correct. Okay.